Scottish Parliament, and I'm the co-convener of the Scottish Parliament Malawi cross-party group. I'd like to welcome everyone at the beginning. I know at these meetings we like to go around the whole table and introduce everyone individually, but I suspect the table or the virtual table is pretty big at the moment, so that may not be possible. But I would like to mention a few people specifically. This is, I should say, a joint meeting with the Holyrood, that is the Scottish Parliament Malawi cross-party group, and the Westminster Malawi all-party group. I would particularly want to recognise Patrick Grady MP, chair of the Malawi all-party group, and Lord McConnell as the group's honorary president. I would also want to mention a number of members of Parliament, both the Scottish and UK Parliaments, as well as distinguished
I'm on mute, so they can't hear me.
From Malawi. I think somebody needs to switch their mute on. I think I'd like to recognise a number of people, as I say. Patrick Grady I've mentioned, but also I believe Philippa Whitford MP will be joining us, although she might be late. Linda Fabiani MSP, who's the Deputy Presiding Officer of the Scottish Parliament. Lord McConnell I've mentioned. Lisa Cameron MP hopes to attend, as does Elaine Smith MSP, Liam MacArthur MSP, Owen Thompson MP, and Stephen Doherty, I never know whether to say Doherty or Doughty MP. I'm keen also to specifically welcome and thank the two ministers who are taking part in today's meeting. Those are the Honourable Khumbize Kandodo Chiponda, Member of Parliament, the Honourable Minister in the Malawian government with responsibility for health, and Jenny Gilruth, Member of the Scottish Parliament, the Scottish Government's Minister for Europe, Migration and International Development. And there are other distinguished participants in the meeting tonight, both in Malawi and Scotland, including Frank Ross, the Lord Provost of Edinburgh, and co-president of the Scotland-Malawi Partnership. We had invited the UK Government's Africa Minister and the British High Commissioner to Malawi to take part in this meeting, but both declined, and no alternative speaker from the new FCDO ministry was forthcoming. However, I appreciate it was organised at reasonably short notice, but many more parliamentarians wanted to join us but were not able, and thus have given apologies. Those would include Ian Murray MP, David Mundell MP, Margaret Ferrier MP, Deirdre Brock MP, Oliver Mundell MSP, Alec Cole-Hamilton MSP, and Stuart McMillan MSP, as well as Alexander Stewart MSP. So you'll have seen from the agenda we have many people here and a relatively short time. We hope to finish at, in Scottish time, 7:30 or Malawian time 9:30, and we appreciate people staying on later at Malawi and being so helpful about that. The first thing we have to do before we get started is just to agree the minutes of the last meeting. I believe these will now be available somewhere in the chat box function, which you should see on screen. David, is that something you've got to hand, is it? Or?
Yes, just posting now.
Very good. So if there are any matters arising from the minute, if people could let me know. And if not, if people could indicate whether there's a proposer and a seconder who are prepared to agree the minutes.
I'm happy to propose the minutes are fine. It's Tracy Morse.
Okay, that's proposed by Tracy Morse.
And I would be prepared to second that.
Seconded by Brian Kerr. Thank you very much. In that case, if there's no matters arising directly from the minute, we should really get straight to the business of tonight's meeting, which is the very concerning situation, sudden and serious worsening of the COVID-19 situation in Malawi. And I think there's a great deal of goodwill at this meeting to explore what more Scotland and the UK can do to support Malawi at this critical time. We have got 3 sections to the meeting, and I believe again there'll be more information in the chat box about the agenda. But the first section is our core briefings with time for question and answer and discussions with our main speakers, the ministers from Scotland and Malawi, and also a representative of the People's Vaccine Alliance. The second section looks to listen to wider Malawian perspectives from civic society, business and the diaspora, and our speakers have been encouraged to share their own experiences. And the third section gives brief examples of collaboration with Malawi in fighting COVID. So we'll have time at the meeting, I hope, if we keep the schedule, to discuss exactly what our two parliamentary groups in Scotland and the UK might be able to do and to recommend, informed by our discussions today. I haven't counted the participants, David can probably tell me, but there are a good number. So I may not be able to bring absolutely everyone in, but if people have views, if they can indicate them in the chat box, David, don't hesitate to interrupt me if I'm missing important points in the chat box and point me to them. I will try to bring people in, although sometimes for reasons of time, I might have to try and quote people rather than bring them in directly. This is a public meeting, so it will be recorded and will be made available online. With that in mind, if I could again remind people to keep microphones on mute unless you're just about to speak. All are welcome to have their cameras on. It doesn't seem to be causing difficulties, but if you could remember to mute when you're not speaking. So without any further delay, I'd like to say how pleased we are again to have the Honourable Minister for Health from Malawi as our keynote speaker and our very honoured guest. We're extremely grateful for the Minister's time during what we appreciate must be an exceptionally difficult and busy time. So can I, in that case, please offer the floor to the Honourable Minister. We greatly look forward to learning about what you have to tell us this evening.
Honourable Minister, I've received your presentation by email and I have that on the screen now. So if you're happy to unmute and speak, and if you just say slide, and I will transfer slides as you direct. Over to you, Minister.
Hello, good evening. Thank you so much, honourable colleagues. It is an honor for me to be present in this virtual meeting, especially on COVID-19 pandemic. And we really appreciate your statements by thinking about us. We know as well that even your countries, you are not spared at all. But we appreciate that you have taken time to hear how we are doing here in Malawi. So I don't take it for granted. So can we move on? Next slide. Okay, that's just an outline of the whole presentation. We can move to the next slide. Yes, this is just to give you the timeline of events from 2019, the 1st December, when the WHO alerted of the pneumonia cases in China. But here in Malawi, we had our first case, that was March 2020. And then in April, we declared a state of disaster for the country. So from April, May, June, July, that's when the numbers started increasing. That's when we had like the first wave, May, June, July. So we lost a number of people, also including our health workers as well. We lost about, that time it was about 700 health workers. And then June, July, August, we peaked, and then the numbers started going down. We also gazetted new rules in terms of how to manage the COVID, in terms of preventive measures as well, so that we do public awareness so that our people, they should know how to handle it, and also trying to minimize the transmission. And then September, we opened up a little bit in terms of the social sector as well. Even some of the restrictions, we eased them and life was a little bit back to normal. They were still encouraging the measures which we had put in place. But then the cases started to rise again soon after Christmas. Maybe it was because of the festive season till now. So here we are. So we can move to the next slide. Next slide. This slide, it shows comparing the region, because Malawi, our neighbors, the Zambia, Mozambique, Tanzania, we have put South Africa because we are very close to South Africa. Our people, they're always traveling in between South Africa and Malawi because most of our goods, we get them from South Africa. So we have added South Africa there because most of the times what happens in South Africa also happens this side of the country. We have also included Kenya as well, just to try to compare how the numbers are looking. So you can see from the graphs that that is of 19th January 2021. South Africa seems to be peaking as we're talking now. Also Zambia and also Kenya and Mozambique. But ours, the numbers, they're still rising. So we can go to the next one. This, it also shows the number of cases. You can see the first wave, the numbers were a little bit low. And now you can see the second wave that cumulatively the numbers have gone very, very high. Next one. Next slide, please. Okay, this one also shows you this one shows you the admissions as well as the death rate as of 17. As of today, we have had about 19,987 confirmed cases in Malawi. I know there could be more, but because of we are limited in terms of testing, you know, it is targeted. But if we had enough testing kits and we tested more, we are very sure that this number could have gone up. Now, in terms of the people who have died as of 25th of January, about 518. In terms of admission, we have about 250 who are admitted in our hospitals. But that is also because we know that some that in private hospitals, the numbers I'm giving, those are just public hospitals. But we know for sure that some are in private hospitals because of the limitations of space in our public institutions, especially the hospitals, especially the big hospitals. That is Kamu Central Hospital, which is here in Lilongwe, which is a capital. And then we have Queen's Central Hospital, which is in Blantyre. We're trying to increase capacity in terms of the isolation centers. So in Queens, which is in Blantyre, we have a capacity about of 80 beds, but now we are trying to put up a tent, which is going to accommodate maybe about 150 beds. That process is still taking shape. I think maybe by next week, it will be available. But what we have done also is that we had some sort of Blantyre Youth Center. It was like a park for our kids to play basketball and everything else. Now we have also turned that into an isolation center, and works are progressing as we are talking now, where we are thinking that we can also maybe accommodate maybe 100 more beds. Now here in Lilongwe as well, we have turned our stadium, that is the Bingu National Stadium, one of our biggest stadiums. We have turned it into an isolation center, and that one can accommodate, that one will accommodate, yeah, that one we will accommodate about 300 beds. So that one, we are hoping that at least by Friday, it will be finished. We are still trying to pool resources to equip it, because it means we have to pull staff from the other hospitals for those additional isolation centers. But also it means we have also to pull necessary equipment for the new isolation centers. So we are doing that, but we are under so much pressure that we said we just need to start. It might not be 100%, but we need somewhere to keep our patients, because Kamusento Hospital, it's besting at, it seems they have absolutely no room there. But we are also fortunate that our president has also given us one of the state houses, which was in Zomba, so that we can also use it as an isolation center as well. So now we're also looking at that, trying to see what is it that we can do, and how can we get the necessary equipment, manpower, and everything else, so that we make it an isolation center as well for our people in Zomba. Zomba will cover the eastern region of Malawi. As of 24th of January, 2021, you can move to the next slide. Sorry, David, I was just going on. Yes, the next one. Yes, so that is, no, go back. Yes, I wanted to share this information. That is the overview of, these are the health workers which they have also tested positive in the system. 917 healthcare workers. Unfortunately, we have lost 6. All the 28 districts are affected here in Malawi. The high burden places, like I said, the cities, which is Blantyre, Lilongwe, and Zuzu. Now on this one, I just wanted to share more, because as a country in our health system, we already had a high vacancy rate of about 50%. So now with this, it means we withdraw 917, which we have to quarantine, we have to look after them. So that creates even more pressure on the system. So as a country, we need to recruit more health workers so that they can fill the gaps in the hospitals, but also they can take care of the new isolation centers which we are putting up and trying to open over the weekend. Next slide, please. Yeah, this is just to show the distribution of the health worker cases. Below there, those are our districts in Malawi. You can move to the next one. This is more of the same, the health worker COVID cases distribution, and also showing you that most of those affected, there have been nurses amongst them, and of course clinicians as well, and also from the lab. Next one. Okay, the next one. Yeah, this is the public health measures which we had tried to put in place so that we minimize the transmission. Testing, I already talked about testing. We are doing limited testing. We do not have enough test kits. So it's targeted. So only those who present symptoms, entrance from outside, and also high risk, and also those who are going outside Malawi, those who are traveling, and those are the ones we are testing. Tracing, we also try to do tracing, especially of the patients, and trying to follow up on the contacts, close contacts only, who came into contact with them while at home. Quarantine, we do quarantine, but most cases we say they have to quarantine at home and try to manage to follow up. And we also provided, we have a toll-free number, 929, which we have established so that those in quarantine, if they need extra help or they're stressed or something like that, we can attend to them. But also have some other numbers for all our institutions across the country in all the 28 districts. Self-isolation, we do that as well. There's infection prevention and control in healthcare settings and community. Mandatory masking, we're trying to enforce that, though it's not very easy. Some other people, they still don't understand it, but we're still trying to force it. In the rural areas, it is very difficult, especially the mandatory wearing mask. As a country, we have said now we're in the process of producing cloth masks, which should be distributed in the rural areas, especially to the vulnerable groups, to the elderly, and also to all school-going children. We need to give them the cloth mask, which they can wash and reuse. Risk communication, we also have strategies put in place to address that. And the enforcement of the 3 Ws, we are also trying that, wearing a mask, washing hands, and also watching the distance. Compliance is a problem amongst all those 3, but we are still trying to do our best in terms of sensitizing the public. You can move to the next one. Next slide. Okay, the next slide, I wanted to talk about the vaccine. As a country, we are on a COVAX platform under WHO and Gavi. So on that one, we have been promised that they can take care of only 20% of the population. That is on the COVAX facility. We are assured of only 20% of the population, which is about 3.8 million Malawians. Of course, our plan is that when that is available, we start with the high risk, the health workers, the elderly, and also those people with the comorbidities, because those are high risk as well. We will have a national vaccine deployment plan under development. It's not yet finished, but they're working on it. We have a team of researchers, doctors who are helping us on that one. We also have a community engagement strategy on COVAX, which is also being developed, because we feel it is very important for our people to understand how this vaccine is going to work, especially that these days there's a lot of propaganda with the social media and everything else. So it is important that the Malawians, they'll understand everything about the vaccine, that is going to be safe for them, that is going to give the needed protection, and that it's not going to be mandatory to everybody else. No, so those are the things which we are looking at on the part of the vaccine. Of course, as a country, we need to make plans on how to get the remaining 80% for the population. Next one. So these are possible areas needing support. Human resource, I've already talked about the human resource, that we have a high vacancy rate in almost all our hospitals and health centers. And the COVID is even making it worse because we have to withdraw those who get sick in the process, in the line of duty, for them to recover. Fortunately, most of them, they recover and they come back into the isolation or they go back to work. That is how dedicated our health workers are. Of course, PPEs, you can never have enough of PPEs because, you know, in the hospitals, they're disposable. You use them, you have to throw it away, you know. So we cannot have enough of the PPEs. And of course, oxygen therapy, it is the biggest issue as we are talking now, because most of our hospitals, we did not have the oxygen plants in the hospitals. So we only managed to get a plant 2 months ago, which is servicing Kamuzu Central Hospital, but that is not enough because it is supplying to the main hospital, but now you have the isolation centers which are not connected. We don't have the pipes from the plant to the isolation. So we have to fill the cylinders and physically take the cylinders to the isolation center. A plant is the same. They also have a plant, but it's not enough. So we have to get extra cylinders. Unfortunately, now it means all the districts, because I think almost all the districts, you have 2, 3, or 10 patients. It means we have to give cylinders to all the districts. So oxygen therapy, it is our biggest challenge as I'm talking now. It is huge. We are really, really challenged on oxygen. Of course, the face mask and the cloth, which I've talked about, which we need for our people. Yes, I think I have covered everything. I just forgot just to add that we also have the northern region of Malawi, because I talked of southern region, Blantyre, and then I talked of which is the caters for central region. We also have Mzuzu, that is the northern region. Also there, we have a stadium which we are also putting up an isolation center. Zuzu, it is a problem because there we don't have the oxygen plant. So it means it has to come from Lilongwe or from Blantyre. And with the situation where a patient uses 3 cylinders before on a daily basis, it is a huge challenge financially as well. So these are the issues which we are facing as a country, especially with this COVID pandemic. But I thank you so much for giving me the space to talk a little about the situation in Malawi. And I'm here if there are any clarifications which you need. If there are any questions, please feel free. Thank you so much.
Thank you very much, Honourable Minister. We have lots of questions and comments on the back of a very interesting contribution that you've made, and we will come to those. I see David has his hand up there. Do you want to come in, David? No?
Apologies, no.
Oh, okay. In that case, well, thanks again, Honourable Minister. Some of the things you've mentioned are familiar. Some of the challenges you face, of course, to us are very unfamiliar. And it's very useful indeed to have your observations about the situation in Malawi. Our next speaker is Jenny Gilruth, member of the Scottish Parliament, Minister for International Development in the Scottish Government. I don't know if Minister, you intend to say anything about Scotland, but or the situation in Scotland, but I think you'll be able to say a great deal about our ongoing relationship and all this with Malawi. So we look forward to hearing from you, Jenny Gilruth.
Absolutely. Thank you, Alasdair, and thank you for the invitation to join you all this evening at your special joint meeting with the Scottish Parliament CPG and the UK Parliament's APPG. I'm really delighted to be here tonight, and in particular I want to pay tribute to the Honourable Minister for Health, who we've just heard from, which I think gave us a really helpful, comprehensive, I would say, update in terms of the COVID-19 situation in Malawi. We met recently, actually, in December to discuss the Scottish Government's review of our programme in light of COVID-19. But of course, the world has moved on since December for all of us. And before I take this opportunity to outline the Scottish Government's response to the pandemic, working with Malawi in response to COVID-19, I'd like to express my condolences to you, Honourable Minister, and to the Government of Malawi on the passing of the 2 Malawian Cabinet Ministers recently. Our thoughts are with you all at this time. This is indeed an unprecedented global crisis, leaving no country or people unaffected. It's something we are all also too aware of in terms of our own efforts here in Scotland, as Alasdair mentioned, in terms of the fight against COVID-19. I've spent most of my day, it being a Monday, dealing with constituency cases, many of which are related directly to our fight against the virus here in Scotland. But the strain in terms of our National Health Service is being felt here in Scotland, and the resulting difficulties in terms of the decisions that all governments are having to take nationally, particularly in light of the new strains of the virus. I understand that the COVID-19 pandemic has put an enormous strain on health services in Malawi, and I noted Malawi's new strategy to combat COVID-19 as outlined by President Chakwera just over a week ago now. And it is in these times of crisis that we must stand together to support and protect the most vulnerable. This is not a time for richer countries to renege on their global commitments. Indeed, at this time of national and global difficulty, the Scottish Government continues to stand by and to work with Malawi in its response to the pandemic. As many of you know, last year the Scottish Government's Programme for Government committed to a review of our international development work in light of the pandemic and of the Black Lives Matter movement. A real key aim of that review is to refocus our contribution in terms of international development on areas where we can make the biggest difference against this new backdrop of COVID-19. Back in early December, I had a really good meeting with the Malawian government, both the Ministers of Health and Foreign Affairs, on our review of COVID-19 and also on our joint key priorities going forward. And I'm looking forward to continuing this dialogue with the government of Malawi as we implement the outcomes of the review. But I've also undertaken a large number of stakeholder engagements to seek an input into the areas covered by the review, including events specifically targeted at engagement with Malawian civil society, because this can't just be about government to government. We have to get that wider buy-in from civil society. So I'm hoping to give an update in terms of the outcomes of the review next month. Obviously, parliamentary business pending, things are a little bit different in Scotland at the moment in light of the new lockdown restrictions. In September last year, the government also announced that we had set aside £2 million to contribute to the COVID-19 efforts of all three of our African partner countries, Malawi, Zambia and Rwanda. That's a fifth of our international development budget within the current arrangements. And in allocating that funding, I really wanted to ensure that it would be used to support national government COVID strategies and that preparedness for COVID vaccines. We chose to partner with the UN body UNICEF, and given their reach in relation to children across all three of our partner countries. In relation to Malawi, we've now provided a third of this £2 million funding, around £650,000, for UNICEF Malawi to contribute to activities in support of the government's national plan. That includes providing 400 healthcare providers trained in detecting, referring and appropriate management of COVID-19 cases. And it also includes 400 healthcare facility staff and community health workers trained in infection prevention and control. I'm really pleased that our funds will be used to help prepare the health systems in all of our partner countries, but of course, there's always more that we can be doing, and I'm keen to hear more from people tonight at the CPG. As I know, members of both the CPG and the APPG will know, of course, that the funding we provide in Scotland is an additional spend because international development is largely a reserve matter. But I think it says something about our values as a country and a government that the International Development Fund spend in Scotland has increased since 2005. Of course, its inception was back in 2005 under a Labour administration. I know that Lord McConnell's with us tonight, and it's something that my party has continued with in government and has real cross-party support, as we saw recently in the debate that I held back in October with regard to the review. And on the issue of access to vaccines, which we've heard about already today, and I'm sure we'll come to in terms of the questions, but in terms of those in low and middle income countries, I share that real concern of those in the meeting tonight, I'm sure. And I also agree with the recent statement made by the WHO that the world faces a potential moral catastrophic failure if COVID vaccines are delayed in Africa, whilst wealthier regions focus on ensuring the vaccination of their own. And just last week, we heard from the UN Secretary General in welcoming the United States stated re-engagement with the World Health Organization, which was great news, who said that now is the time for unity and for the international community to work together in solidarity to stop COVID-19 and its shattering consequences. And I wholeheartedly support and welcome Secretary General Guterres' plea to the world on international solidarity. Vaccinations, though, as we know, are the route out of the devastation that's caused by COVID. And that is why the Scottish Government is really engaged in ongoing conversations with UNICEF on that issue. As I indicated a few moments ago, UNICEF are working with our partner countries on that preparedness, getting countries and their systems ready for rapid redeployment. And that includes ensuring the cold chain is in place, communications on prevention and vaccine safety, and also transport and upskilling community outreach teams. I hope the funding provided by the Scottish Government to UNICEF is going to play a vital role in supporting that work. But we're also continuing to monitor and look at our projects on the ground to allow them to adapt where they're able to do. So that might look at providing PPE. We've also looked at how we might be able to support digital education, for example, through some of our projects as a result of the pandemic. And turning in closing, I suppose I'd like to just again thank the convener for the opportunity to be with you tonight, and of course to the Honourable Minister for her contribution to look forward to continuing my conversations with the Government of Malawi as we work together to overcome the impact of this pandemic. And I know that it's not been touched upon yet, convener, but it is of course Burns Night in Scotland tonight. So in that spirit of solidarity, I'll quote from the Bard himself, and I think it would have been his 262nd birthday this evening if he had lived that long. For all that and all that, it's coming yet for all that, that man to man the world o'er shall brothers be for all that. Thank you, convener. I'll pass back to you now.
Thank you very much, Minister, and sentiments with which I'm sure we can all agree. I think we've got lots of questions coming in, and I'll try to get to some of them. But before we do that, we've also got looking at my list here. We've also our next item is Malawi's route to COVID-19 vaccines, and we're very pleased that Nick Dearden, the Director of Global Justice Now, which is part of the People's Vaccine Alliance, is able to tell us something about that. Some of our questions that we have coming in are actually about vaccines, so that's very helpful to have you here, and we look forward to your contribution.
Thanks very much, Chair. It's a great honour to be here tonight on this really important topic. The People's Vaccine Coalition includes campaign groups like mine, Global Justice Now, but also some of the bigger humanitarian organisations like Médecins Sans Frontières and Oxfam, and a whole range of experts and politicians around the world. And many of our organisations have been working for many years now to explain the serious flaws in the way that we research, produce and distribute medicines globally. They are problems that I know some of you on this call will be familiar with from back in the 1990s, the AIDS crisis in Southern Africa, but they continue in many forms today, including our efforts to try and treat hepatitis C around the world. And we really thought that at the beginning of the coronavirus crisis, there seemed to be a real interest and will to overcome some of these well-known problems and do things a little bit differently. And in particular, we saw the World Health Organization coming up with an initiative pushed by countries like Costa Rica to share and collaborate openly with the science and technology and know-how around treatments and vaccines on coronavirus. And that's where they set up this mechanism called CTAP. It was a kind of patent-free open source system where companies could come and contribute what they knew, and others could build on it and use that science and know-how freely. And then we also saw the use and the establishment and the use of the international mechanisms like COVAX to play a role in both speeding up research and fairly distributing vaccines around the world. And the minister's already told us a little bit about COVAX. And this is really important, obviously, because if we don't vaccinate people around the world on a fair basis based on need, on how vulnerable they are and how much they're coming into contact with this virus because they're health workers or whatever, it's going to run unchecked through many parts of the world for many years to come. And that's not only unfair. Research predicts that it will mean many more people die on a global level if we only offer the vaccine to some parts of the world and not others. And what's more, mutations are going to continue arising at a fast rate, and of course they're going to threaten the health of all of us. At some point there will be a blowback to those of us here as well if mutations continue, and mutations are increasingly resilient to the vaccines that we've produced. So if we're really all in this together, we need to work together in a way that's fair and collaborative. And sadly, the medical research model that we've got at the moment doesn't make that easy. And indeed, despite the good intentions that I've spoken about at the beginning of the crisis, we're now in some ways in precisely the situation that we wanted to avoid at the beginning. So CTAP, this mechanism which was all about sharing the science and know-how and building on each other's strengths, has received precisely no contributions from the companies working on vaccines and treatments. And indeed, all Western vaccines that have been produced so far are under patent for a minimum of 2 decades. COVAX has indeed bought vaccines for use all around the world, but particularly in the global south. But there are several problems. One, as the minister pointed out, that even in the best scenario, it's only going to be enough to vaccinate 20% of most countries' populations. That's nowhere near enough to create a kind of herd immunity in those countries. But also COVAX at the moment doesn't even have enough money to procure that many vaccines. And even if it did have more funds, sadly, rich countries like our own have bought up most of the Western vaccines on the market at the moment. So we got a little bit of good news today about Moderna's vaccine, that it was apparently very effective against the mutations we're seeing at the moment. But sadly, the predicted supply of Moderna's vaccine for 2021 has been entirely sold to rich country governments. It's also very expensive, despite the fact that it was funded entirely with public money. And this is the problem that we see again and again in this field. And the upshot of this is that while countries like Britain have spoken well about the need for international distribution, they've also signed oodles of bilateral trade deals, which have meant in practice that they've bought up several times the doses that they need to vaccinate our entire population. While at the same time, most countries in the world have no vaccines at all. Indeed, if you just look at the lower income countries, the lower income country group has only vaccinated 25 people, all in one country in Guinea. And the rest of the countries in the low income group do not have vaccines at the moment. And what we're looking at the moment, there was some great reporting over the weekend in the Financial Times and the New York Times, is countries as diverse as Bangladesh, Tanzania, and Peru having to wait until the end of 2024 before they can come close to vaccinating their entire populations. We also learned on Friday that South Africa, which is in a desperate situation with coronavirus at the moment and is scrambling to vaccinate its frontline nurses and doctors, none of whom have received vaccines yet, ended up having to sign a bilateral deal to get emergency medicines and ended up paying 2.5 times what European countries have paid for the vaccines that they have bought. So the very opposite of the situation we hoped to create. So we need some pretty far-reaching action. I know I've not got long tonight, but one of the things I really do want to mention is that we're supporting the governments of South Africa and India, who enjoy the support of most countries of the Global South, to suspend the global patent rules known as TRIPS at the World Trade Organization, that would allow all countries to share the technology and know-how around these vaccines, but also around treatments and also around equipment like ventilators. We believe that would really help to overcome some of the artificial scarcity, because of course we don't have enough vaccines at the moment, but one of the problems is because of the patent system, there is an artificial lack of supply, an artificial limit on the supply, because not everybody can produce these things unless they receive a license from the company that owns the patent. So we believe it's really important to move on that. The UK government is opposing that at the moment, but talks are continuing at the World Trade Organization with a very important discussion going on in March to decide where we go next. So that's definitely something we would absolutely love as much support as we can get from some of the politicians and decision makers here tonight. Of course, I won't pretend that solving the patent issue and sharing the technology is enough on its own. Of course, we need more manufacturing around the world. We need to repurpose manufacturing facilities and build manufacturing facilities. That's not going to be quick. It's definitely something that would be incredibly useful if governments like ours could support around the world. And of course, we're going to need to be producing vaccines and other treatments at a very high rate for years to come. This is not something that's going to be solved at the end of this year. So investing in that manufacturing capacity in countries of the Global South, I think is something that's going to hold us in good stead in the future. And I think, and I'll just finish on this, not to do so, not to take this radical action at this time, it's not only unethical, but as I say, it's going to mean that the fight against this coronavirus, simply for us here in Britain, it goes on and on and on. And it really is the case that none of us are safe from this disease until all of us are safe. Thank you.
Thank you very much, Nick. Because we're running a little bit behind time here, I'm going to take an executive decision that I'm afraid I might not be able to draw people into this conversation just because of the time it takes. But I'm going to try and summarise some of the points that I've seen from some of the speakers, or some of the correspondents rather, in the chat box, and put them to our three speakers here just now. The first one maybe best answered, or the first couple of questions maybe best answered by the Honourable Minister Chiponda from the Malawian government. Carol Finlay from the Church of Scotland has asked about the situation in rural areas, and particularly in northern areas of the country, and whether there are still people dying at home rather than hospital in many parts of those areas. And her other question, Honourable Minister, was about the supply of face masks, or not her question, but several people asked about the supply of face masks and the enforcement of the wearing of face masks. So I wonder, Minister, would you be able to comment on either of those two issues at all? I think you may be muted, Minister. Yeah. The two issues there were about face masks and about the situation in rural and northern parts of the country.
In fact, as a government, we have a directive from the president where we have been given 1 billion Malawian kwacha just to make mass production of cloth masks just for the rural areas. Like I said, we're targeting the elderly, the vulnerables, those with the other conditions, the high risk, I should say, and all the school-going children. So that is a priority for us now as a country. In the cities, it's a little bit better. People, they can afford to buy a mask. But as a government, we are targeting those vulnerable groups so that we give them the free masks. And the strategy which we are going to use is that we decentralize so that they have to be produced locally in our districts, but then we do quality control. We have to teach them on how to make a proper mask in terms of how it should be double cloth and everything else. So we are giving the specifications, we are giving the training, but we also have our prisoners as well. Some of them, they've been trained as well, you know, to use them with, we had some other good people that have donated sewing machines to our prisoners as well. So we're also going to involve them in the mass production of the mask as well.
Thank you, Minister. This is perhaps a question for Mr. Dearden, or may indeed be a question for the Malawian government, but Antonia Ho has asked about the allocation of vaccine, particularly the COVAX allocation versus the African Union allocation. I don't know if you want to say anything about that, Nick, to begin with, and then perhaps I don't know if the Minister wishes to come in on that as well.
Well, actually, the Minister might know more than me. We're a little bit unclear at the moment about how some of those distributions are going to work out from both channels, actually. So I honestly, I'm not completely sure at the moment.
Minister, the question really was whether Malawi was getting its fair share of the African Union allocation. I don't know if you're able to say anything about that.
As of now, can you hear me?
Yes, Minister, yeah.
Yes, as of now, the only the only platform which we have as a sure platform, it is the COVAX. We have not received any communication if African Union they are capable of getting any vaccines. We have not received that communication yet. So it's just the COVAX, which is the assuring of 20%. Like I said, of the population, we are over about 16 million in Malawi. So the 20% is just about maybe 4 million. That is way below what we need as a country.
Okay, thank you, Minister. Jenny Gilruth, I haven't brought you in yet, but I don't know if you want to comment on any of that, or one question that's been asked by Edward Masika and others has been about, well, both misinformation about vaccines and also hesitancy or fear about vaccines. So I don't know whether you want to comment on Malawi or comment on Scotland, but there may be things in that, or indeed anything else you wish to comment on finally, Jenny.
Thanks, Alasdair. Well, I suppose just to reflect on where we are now with the situation in Malawi. I remember back when I was appointed, so that was February last year, at the start of the pandemic, and asking officials for an update from our partner countries about where we were. And right at the start of the pandemic, our partner countries, particularly Malawi, were in a much better position than we were in Scotland. And they were able to deal with the virus. They were the position that presented itself in March, certainly to our partner countries, was not the one they find themselves faced with now. And we know, of course, of the different strains, particularly the one from South Africa, which has been mentioned by the Health Minister this evening. So I think we certainly, as a key partner with Scotland and Malawi, we need to work with Malawi to do all we can to help support them in the fight against the virus. We've been through potentially the worst of it. Hopefully, we all hope the worst of it as we progress towards getting everybody vaccinated. And of course, there will be challenges with that. But I think what I'm hearing today is, in terms of the vaccine, that we need to help more directly with some of that work. And I'm really keen, particularly, to work with the UK government on it. I'm very keen to speak to Mr. Duddridge, actually, about the role of the UK government in this. You will appreciate, of course, that international development is largely reserved. But nonetheless, we have a key contribution, I think, to make in Scotland. I've outlined some of what we're doing within the confines of devolution at the moment in terms of our COVID spend, but I'm really keen that we do more. So if that message might be relayed to the UK Government Minister by MP colleagues who are on the CPG call this evening, I'd be very grateful. And certainly I'll take away what more we might be able to do at the Scottish Government end of things in terms of the vaccine and how we help to assist in the rollout. Because I think the point that was made by the last speaker is we're not safe, all of us aren't safe until, none of us are safe until all of us are safe, rather. So it's hugely important that the vaccination rollout is supported at all levels, and it's not just this kind of free-for-all from the richer countries, which I think we have seen, unfortunately, thus far in the rollout of the vaccine.
Thank you very much, Minister. As I mentioned, we're running a little behind time, but the quality of what we're hearing makes up for that. So I think what we'll move on to in that case is some wider perspectives from Malawi, and those are to be led by Ms. Habiba Osman of the Malawi Human Rights Commission. I think before we hear from Ms. Osman, it's as well for us to record our sincere condolences on the recent passing of the Reverend Patrick Samfere, who was the chairman of the MHRC, who sadly died of COVID only on Thursday, which, as well as being a very sad occasion, is also a very sobering reminder of the situation which both our countries face. So we would like to pass on our condolences about his loss, and also to introduce you to hear about what it is that the organisation you represent is doing.
Thank you very much, Alasdair, and thank you very much, David. I'm delighted to be here tonight to be giving a perspective of the human rights situation on the ground. And I think first and foremost, let me also just appreciate the fact that we are going through unprecedented times, and we are very shaken. I think when we were talking about the pandemic in 2020, we didn't visualize a situation where we would even have people that are near and dear to us lose their lives because of the pandemic. And interestingly, that ironically, just 2 days before the chairperson died, he made us release a statement where we were giving recommendations on the issues of COVID-19, but also just calling out for decisive leadership that is very inclusive, but also that would really be targeted at making sure that civil society is involved and other people beyond a government, because this crisis really, the recovery, when you look at it, it goes beyond government. It really requires that the private sector, academic institutions, civil society must be fully engaged. And this is a call for human rights, for Malawi human rights. And basically, I think what we've also noted is that the lack of adherence to measures that have been put in place, it has been basically because of the weak civic space or weak civic education that has not really come out very strongly. We have actually condemned, as Malawi Human Rights Commission lately, the brutality by the police when enforcing people to wear masks. It just shows that there is need for rigorous civil society engagement, but also including other actors to come in to assist in the pandemic. And again, I think at the core of it all, we are saying that the recovery itself must be holistic. It must really consider human rights issues, because what the minister has said that, you know, they're targeting vulnerable people in the villages, in rural areas. Let's not forget that we have the urban poor. So as much as, yes, we do have poor people in the rural areas, we have the urban poor right in our cities. How do we take care of those? We have street children, and we have even prisoners as well, as somebody had pointed out. So for us really is to say that we must also have other measures, for example, maybe cash transfers, credits, loans that should be targeted, for example, to civil society organizations that can work with these vulnerable groups to assist them during this crisis. As much as government can provide the masks or PPE, it is not sustainable. So we do need also the private sector and others to come in to assist, even local businessmen, small business, medium income sized NGOs, whatever you name them. Everyone needs to put their hands together to assist in this crisis. But also maybe one more thing, because I know my time is running out. Government has gazetted certain rules. Maybe the Scottish government can also assist us in terms of how they disseminated those and how they popularized the rules that they gazetted. If they gazetted rules, for example, I know that the UK did so. Again, beyond that, the issue that I think we are facing, the minister has just said that 917 health workers are struggling right now with the COVID. The issue of mental health, I think, is missing within this discussion. We really need to make sure that our front runners, everybody else, is really getting the necessary help, the advice, the counseling. I think we must include issues of mental health as we are really discussing the issues of COVID-19, because the health workers are even fearing to go to their homes because they may affect their families. And school children, some that are in school right now, some are panicking because everybody knows that the pandemic is a killer, is deadly. So I think issues of mental health also must really be put on the agenda so that we are able to assist the population as well as people that are suffering. And finally, I think the issue of the vaccine has been mentioned. I think government must really come up with a plan to show how they are going to disseminate the information, because we have a culture that is going to resist, that is still resisting, and that doesn't believe that vaccines work. So I think we do need a plan, and that plan must be brought out now, immediately, so that we know what these vaccines are all about. And in that way also, we are going to demystify and deconstruct the narratives that vaccines are dangerous, vaccines are unchristian, etc. Thank you very much.
Thank you very much indeed. That was very helpful, Habiba. And we'll hear another perspective, quite a personal perspective now, because our next speaker is Dr. Matthews Mtumbuka, former chair of the Malawi-Scotland Partnership, who lived many years in Aberdeen, will be known to many people at the meeting, I suspect. And he is thankfully just out of hospital, having suffered from COVID. And so he's able to share a very personal experience, as well as his own reflections professionally and through his organisation on the situation in Malawi. So we're very thankful to hear about the better news about your health, and we look forward to hearing from you now.
Thank you so much, Alasdair. Thank you. I'll keep my 5 minutes. Indeed, I'll speak more as a practical example of a survivor of COVID. I was sick, and I went to Government Central Hospital, I must give a disclaimer. The last time I went to government hospital when I was a student in university in the late 90s. For 2 decades, I've always gone to private hospitals. And with COVID, my only hope was government hospitals. And Honorable Minister, through you, I would like to thank you, the government, for saving my life. I had very little chance, but the hospital and the doctors there, the nurses, saved my life. I was in hospital for 10 days from Friday the 15th until yesterday. I was on oxygen for 8 days nonstop, and only off the last 2 days, and I survived. Immediately I arrived there, they put me through the whole procedure routine, protected me against possible clotting, antibiotics, protected my lungs. I was being checked and things. To be structured, because I have little time, I would like to make the following observations. First is that we have a very dedicated health workforce in government system on COVID. They are systematic, they are very dedicated, passionate, and caring. And I think this must be commended and must continue. Our isolation centers are fantastic. The challenge we have is in between you can get to the right attention, because you go to the short stay, you go through the process where they're trying to look at you. During that process, we do not have all the logistical support. The oxygen cylinders are not enough, and I'll come to that. We sometimes have power issues, but on the medical side, I think they're doing a great job. The major challenge, as I mentioned, is on the oxygen side. On Saturday night, at Kamu Central Hospital, the whole hospital ran out of oxygen cylinders. My wife had to go out, make phone calls, and one of my friend doctors at his clinic had 1 cylinder, which my cousin had to drive in a truck to the hospital, which kept me through the whole night. And in the morning, I'd look for 1 more spare cylinder. Luckily, I'd been talking to all the authorities, including the PS for Education, PS for Health, who Dr. Mansambo is a fantastic man. And they mobilize things, they resolve them. So I think on oxygen, we're losing lives. We need continuous oxygen at all times. That I think is a major one. Otherwise, I think that 2 other things we need to focus on is getting people to the hospital in time. Lots of people are brought into hospital dead or near dead. They're dying at home. I think with that, I'll just add to say, I think that we need more business involvement. It's been there a little bit. We have some banks contributing money, but it's uncoordinated. We need it coordinated. I think we should put up a fund, 2 billion kwacha from businesses over 2 months is possible. And then thirdly, we need to focus on the vaccine. And I'm happy to see this discussion about the vaccine. My 5 minutes up. Thank you very much. There's so much to talk. We'll talk more later. But thank you, Scotland, for being with us and supporting us. We'll defeat this. It's a big battle, but we can win. Together we can. People must believe, and people must cut off from the social media. What kills people in the hospital is the bad news. You are there, you hear your cousin dead. You are there, you hear your uncle's dead. You are there, you hear this one is dead. People need to cut off from the negative energy, negative news. If there's one thing that was going to kill me, was hearing friends dying. Thank you.
Thank you. That was a very impressive contribution indeed. And we are very grateful that although you're just out of hospital and most people would, in that situation, just be going to their bed, that you've chosen to spend your evening speaking with us about that very difficult situation for you, but also the very practical advice you've got, which I'm sure we'll talk about later on. Our next speaker is representing Malawian business, as we've heard about just now, which is Joyce Juma-Phiri. Again, will be well known to many people through the cross-party group and also through the Association of Malawians in Scotland. So Again, we hope we can have a conversation or questions towards the end, but we look forward to hearing her just now.
Thank you, Alasdair. Thank you for this opportunity, David, and all protocols observed. And thank you that the Minister of Health, my schoolmate, can be here with us. It's a sad time, and there's no missing words about it. But we do appreciate the effort that the government of Malawi is doing. Mine is not a government perspective, it's more or less a civil society perspective, because as we have seen the rate that COVID-19 is killing people, you can imagine if you are thousands of miles away from home, how that affects you. Over the past 4 days, I've lost 10 of friends and family. So every day it's like bam, 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 bam. And most of us Malawians in Scotland, we work on the front line. So we're dealing with COVID here on the ground, and we're hearing about bad news back home. So it is something that we never have to experience before. We're just trying as much as possible to survive ourselves mentally as well. As Habiba said, mental health is very, very important. So that brings us where we are with the association, is that we said, okay, fine. I think this is the time the diaspora can stand up and be counted, galvanize ourselves with our friends here. So every project that works in Malawi, we are calling upon you. I've spoken to David that let's come together, because most of the times help go to Malawi in isolated cases. So if we in Scotland will come together as a group and have targeted response to that support, it would help us a lot. But also our concern is about, we don't hear a lot about civic education, because civic education is very, very important. How are we gonna bust those myths about what this COVID is? So we need to look at that aspect of sensitizing the communities, especially the rural community or even the urban poor, so that people are making informed decisions. It's not also just about that, it's about the social aspect of COVID. If the stigma surrounding COVID is killing people, so most people are hiding the disease until they reach that stage. How do we make sure that people have got the right channels that they can be receiving the help they want? And also the cultural behaviors that we have, whether it's not separating husband and wife, thereby we are transmitting those diseases. But I'm not an expert, I'm not in Malawi. So for me, it's not to lecture people who are in Malawi. My point here as the chair in Scotland is to ensure that us who have got projects in Malawi, those of us who've got involvement in Malawi, let's come together. Let's not send to Malawi isolated gifts. Let's not use this time to give Malawi items they don't want. We need to work with people on the ground, whether it's the Malawi ministry, the minister's office or civil society offices. We need to find out what they really need. We don't need to send hundreds and thousands of masks to Malawi. I'm sure communities can be enabled to make masks themselves. But there are certain things that Malawi on its own cannot afford. So how do we channel that support for our friends in Malawi? I want to recommend our High Commissioner Ken Chiponda for looking at this and mobilizing the Malawi leaders in UK to gather so that we can form a group whereby we are monitoring on what's happening. And also the Mahekas group and some other good-willing people who are sending help in Malawi. But let's come in Scotland. I want us to stand up and be counted on this. Government in Scotland, the minister here, they can do this side of government, but us, the civic society, we can also do a lot. We are the people who normally deal with the people when we go on the ground. We don't go to government offices. So we are more likely to come up with an organized and united front and help the Malawians on the ground. But also, in terms of things, news that we are hearing from Malawi, you know, theft of government equipment. We don't want to send aid to Malawi that's just going to be misused by somebody who's got a private hospital. We want that aid to be channeled to the people who need it, you know, because COVID is not just for the rich, it's for everybody. So the COVID support that we're going to send, we really need to look at the help that's going to be sent there, that it reaches the people that need it. But that's my call. My call is that David and I, we're going to lead on this. We are asking you, come together with us. Let's have a coordinated response to COVID from Scotland. I thank you.
Thank you very much. That was great as ever. And you reminded me of a very useful Malawian phrase, which I forgot to mention at the very beginning, which was all protocols observed. So I ask for that now. I think we'll look at a different way, perhaps, of doing the questions this time round, maybe more of a free-for-all. I've got lots of questions here. I will invite people to come in, and I will invite Habiba, Joyce, Matthews to come in and say their piece, although probably just one person for one question rather than try and ask it all three to answer the question. So I think a theme that's come through from a lot of the people in the chat box here, I won't try and name them all, is about inequalities around the world with the supply of vaccine, and a lack of discussion perhaps about the fact that there is an inequality between Europe and Africa when it comes to the supply of vaccine. So do people want to come in on that debate?
Can I just say, maybe I'm not a health expert, but that is what we are seeing coming out a lot, that every time there's such things, Africa seems to be on the bottom. So that's the worry, and that's really probably propagating the talks or the myths that are in the community that Africa is going to get second-class, you know, vaccine that's going to kill the African population, and why is Africa not getting vaccine now? So we really need to balance this up, that if it's the vaccine, why should we have a different vaccine for everybody? We need, if there is a reason, if it's genetics or whatever, there gotta be a proper explanation to why Africa has to receive a different vaccine. But most important is the equality and equity of disseminating the vaccine among all the population, because we have the vulnerable in every country, you know, so why are the others more vulnerable than the others? But I think Dr. Mtumbuka is best placed on this. You know both sides of the coin. I will let you handle this one.
Yeah, I think that the important thing in terms of way forward for Africa is to come together, one, as Africa, and two, to get together the experts that we have and put up a team that helps us to negotiate, to wrestle. This is a game of power and politics in health. It's a fact. So we've got, as Africa, to come together and tackle it as is. But we need to be united. We need to come up with a team that is capable and a team that can engage. That's what we need. Not dealing with this as Malawi, as Zambia, as Ghana, as Nigeria, who go nowhere. The African Union is talking things, but they're slow and they're not being very aggressive. I am happy. I noticed recently in South Africa, a team of immunologists and all these experts have come together to study this thing and to face it head on. South Africa is doing that. Why can't we do that at Africa level? That's what we need to do.
Okay, thank you. Well, I don't know, I'll bring in someone who's asked about the issue specifically of oxygen, and that was Edwin Golly-Makara. Does he want to come in and ask, you had questions in the chat box about oxygen? No? Well, if he's not there, the question here is, what immediate and urgent measures have the Malawian government put in place to alleviate the oxygen crisis, which Matthews, of course, referred to himself? But specifically, they're asking again about the northern region of Malawi, and some of the challenges that hospitals there face. So I don't know if anyone wants to talk about some of the issues that Edwin has raised.
Probably the Minister of Health would be the one that question should be directed, because we wouldn't know, like I wouldn't know.
Honourable Minister, would you wish to come in on that, since a number of people are asking about the issue of oxygen?
Yes, like I said before, that Zuzu Central Hospital, it does not have a plant. We're in the process, but then, you know, putting up a plant, it means we have to get everything. And for us, we get everything from South Africa, and it has to come by road. You know, it takes time. But we have commissioned a plant in the northern region. It's in Kataben. Kataben, Zuzu, it's about 30 to 40 kilometers apart. So that plant, it's working. Of course, in terms of capacity, it has a small capacity than maybe the ones at Kamuzu Central Hospital. But the challenge remains the same, that you know, you have to take care of the other patients as well, because we should not forget that we still have the other patients with other conditions which we have to support as well. So that is why that we are getting challenged now to support COVID patients, because COVID, the consumption of oxygen is much higher than any other disease. But we try to balance up that we should not ignore the other patients which we have in our institutions as well, but also trying to support the theaters and the ICUs as well.
Thank you very much, Minister. Somebody who's only appearing on my screen by the name Nokia 2V, so I'm not sure if they know who that is. Do you want to ask your question, Nokia 2V? It's about the idea of vaccination and whether people are resistant to vaccination, especially in rural areas. If you don't recognise who you are, I'll ask the question for you in that case. How best will the idea of vaccination reach people in remote areas in Malawi, as there are strong reports that some people are not ready, and I take it that means willing for vaccination. So are there issues here that we all have to work through together? What's the answer to that reluctance? It's not unique to Africa. We have people who are vaccine reluctant in Scotland too. And again, I address that to anyone who wants to come in. Whoever comes in first gets in.
Hello.
Hello.
Yes. Like I said before, that we have a national vaccine deployment plan. Basically, like Habiba said, we need a lot of awareness, you know, the public to understand. We have to explain to them what is this vaccine. They need to assure us that it is very safe for them, but we also have to stress the point that COVID has no cure. So the only way we can protect our people, it is by giving this vaccine. You know, so we need a lot of assurance, and also we have to involve all the others. We have to involve the faith communities, we have to involve CSOs, we have to involve our traditional leaders as well, you know, to spread this message, to say this vaccine is going to be safe for you, you know. So we have a lot of work to do there, but that's what I can say. So we also have the community engagement strategy, which is going to involve all these groups, all the stakeholders as well, so that we drive the message home about the vaccine and how important it is, you know. And even in the rural, our children in the rural, they get vaccinated, you know, and all the parents, even in the rural, the remotest, they appreciate the use of vaccine which we give to our children. They have accepted it. It is a part of our life, and they have seen how it protects our young ones, you know, when they're born. So it is the same that we have to explain to them to make them understand that this vaccine, it is important. But the thing is, we have to make sure that we have enough vaccine for the people of Malawi.
Thank you, Minister. One of the questions here is from Emily Phillips. Again, I don't know if she's here and wants to ask it herself, but it's about some of the challenges about awareness around funerals. Emily, are you here? Do you want to ask your question?
Yeah, I'm here.
Fire away.
I just observed, we had a funeral for someone that I know, and I attended the virtual program. And when they were at the mortuary at Queen Elizabeth Central Hospital, I saw, because there weren't so many people, so I was able to see who was going in and out. And then they took the body to Zomba, which is about 70 kilometers or so from Blantyre, for burial. I was so surprised to see one of the staff who was so much involved with the transferring the body from the makeshift morgue to the hearse and coming out, was also at the gravesite and was standing very, very close to some of the people and was still wearing the same uniform that he was wearing at the morgue. So my question was, these are healthcare workers who should be trained on not to transmit. And I actually felt really sad that that was happening. So that's why my question is that what is the government doing about training the healthcare workers so that they're not vessels to transmitting the disease, because that was quite dangerous. Thank you.
Again, Honourable Minister, I'll give you the right to respond to
that. Thank you so much, Emily, for that. It is a big concern. Indeed, if that happened, but we have made sure that all our health workers, they've undergone training, especially to do with COVID, in terms of management of the patient, as well as the management of the dead bodies. You know, so we have taken them through, say, okay, if somebody has died from COVID, of course, we put them in a separate mortuary. We do the disinfection and everything else so that the body itself is not a threat to the people. The biggest threat, it is the mourners who come, you know, because you have a lot of people who are meeting from different places. So we have stressed that. And we have also said the burial has to be within 24 hours after the person has died. But we have also stressed on that, you know, in Malawi, our culture is when you die, you want to go and get buried in your home village. That has been our culture. We are still talking to our people to say, no, with COVID, you cannot travel long distances. We are doing this just to minimize the transmission from one person to another of the COVID-19. So we are encouraging that, no, we bury our dead closest to where we are. If we are in Nilongwe, we bury here in Nilongwe. So that is what we are encouraging. And I must say that most of the people, they are complying to the measures which we have taken in terms of management of our dead.
Thank you, Minister. That was a useful discussion, and we'll have to move on now. And in that case, I think I just want to talk a little bit, or to introduce people rather, who can talk a bit about the Scotland-Malawi relationship and collaborations that are going on. So I've got three of those who I want to introduce, and who, if they could maybe say a word or two briefly about their work. The first of those is Dr. Antonia Ho, who is a clinical senior lecturer at the University of Glasgow, and who can say a little briefly about the healthcare worker study that she's been involved in.
Yeah, thank you very much, Alasdair. For those of you who don't know me, I'm Antonia Ho. I'm an infectious disease clinician and epidemiologist, and I previously worked in Malawi looking at flu. So in a very short space of time, I'm going to present some of the work that we have done. So I'm currently based at Glasgow University, but collaborating with lots of Malawian researchers. So this is a healthcare prospective cohort study looking at SARS-CoV-2 exposure in healthcare workers and community members in Blantyre. So obviously at the start, so this was during the first wave, there was obviously concerns that healthcare workers were at greater risk, and particularly those in Malawi may at particularly high risk, given that there is, there are so few healthcare workers and that they may not have access to the PPE that they need. So we got GCRF funding and recruited 150 healthcare workers from the Blantyre District Health Office who were doing the contact tracing, and also healthcare workers from the Queen Elizabeth Central Hospital and also 3 urban health centres, and with some location matched community members. And we saw them at 3 time points, June, July and August, 4 weeks apart. We took nasal swabs from them and also took blood to look at antibody levels. So we looked for active infection with PCR tests in the nasal swabs and did antibody tests, and also looked at kind of risk factors and PPE access as well. And incidentally, we managed to recruit over the peak. As you saw the Honourable Minister's first slides, the peak really occurred towards the end of July. So our findings were really surprising to us in that the majority of participants we recruited had no symptoms whatsoever. But at the first time point, we found that 11% of healthcare workers and 13% of non-healthcare workers had active infection, were SARS-CoV-2 PCR positive. And that went up to 18 and 25% in July, which coincided with the peak of the outbreak, and went down to 6 and 3%. So overall, a quarter of healthcare workers and 30% of non-healthcare workers were positive at any one point. And this differed really by location. But importantly, healthcare workers were not at greater risk. So important to understand that in the first wave, they didn't observe an uptake in severe acute respiratory infection. So perhaps what was observed in healthcare workers was really community transmission. We then looked at the antibody levels. So this is the PCR test. So antibody levels, as you would expect, rose during the 3 months. So it was initially 2 and 9%, and towards the end, 17% of healthcare workers and 25% of non-healthcare workers were antibody positive for SARS-CoV-2. What about symptoms? We recorded symptoms that they experienced within 2 weeks before they were seen. And there were basically there was no difference, the legend's been cut off, between those who were SARS-CoV-2 PCR negative, which is the blue bar, and those that were PCR positive, which was the orange bar. In essence, you couldn't really tell whether people had COVID or not based on symptoms alone. And actually 3/4 of participants reported no symptoms whatsoever. Some people were positive at 2 time points, and only really at the week 4, when we saw a lot of infection, were things like fever, headache, loss of smell and taste able to differentiate people who had COVID or not COVID. So all in all, there was a lot of asymptomatic or mildly symptomatic individuals, and they developed a high antibody response. So we are now looking at trying to source some additional funding to do further follow-up, because we captured this big group of people who had active infection in this cohort during the first wave. Will be interesting to know now there is more infection, whether they are affected. The majority of patients were asymptomatic or had mild symptoms, and those who were SARS-CoV-2 positive were more likely to report fever, headache, loss of smell and taste. I didn't show you this, but we looked at kind of risk factors for infection, and we didn't find any obvious risk factors, but bearing in mind this was a small sample size, and we're currently looking at kind of correlating symptoms and the PCR results with the serology as to who is more likely or less likely to develop antibody tests. So I'm now going to hand you over to Professor Mia Crampin, who I'm collaborating with a large population sero-surveillance study in the central and northern region. Mia, I'm handing over to you now. Mia, are you on mute?
Sorry, my name is Mia Crampin. I'm the Director of the Malawi Epidemiology and Intervention Research Unit, and I'm also a member of staff at Glasgow University and the London School of Hygiene and Tropical Medicine. As one of our earlier speakers said, there is a duty for the academic community to respond in supporting initiatives in the COVID response. And certainly the unit that I'm part of is conducting a lot of studies on COVID to do with excess mortality, impact on maternal health services, trust in institutions, behaviour, symptoms and so on, and also mental health. But the study that I'm going to just tell you briefly about now builds on the work that Tony has just described, and it's a collaboration between multiple Malawian institutions, which you can see there, and the Centre of Virus Research in Glasgow through Dr. Ho, and with Charles Monsambo, Dr. Annie Wale from Ministry of Health, and Victor Mapaso and Tony Nurenda from College of Medicine. So building on that work in healthcare workers, we've designed a large population-based study to answer some questions that are really fundamental to understanding COVID in low-income Africa. The study that we've planned will enable us to look at the proportion of urban and rural residents who've got evidence of prior infection through the kind of antibody testing that Tony described. And also we propose in this to resample a large set of individuals, about 2,000 in total, in the urban and rural populations, to look at incidence in the communities, both symptomatic and asymptomatic. We also plan to do more detailed immunological studies through further antibody tests and also collecting white blood cells. And these T-cell responses are becoming more and more interesting in understanding whether prior infection can protect against disease, including new variants, the opportunities for vaccines to really control future risk of disease and so on. Next slide, please, Tony. So we designed this in 4 stages. The first stage was purely to understand, given that in the first wave there was so little morbidity and mortality seen in the rural areas, to really understand whether it was worthwhile to pursue this in rural Karonga district, where Miru has a research site. And then in stage 2, go on to do some very detailed studies in both urban and rural Karonga and Area 25 and Lilongwe, with samples of 1,000 individuals in each site sampled 3 monthly. And then stage 3 to look at, to pick people out of that cohort based on their responses to actually do these detailed immunological studies. So it would require in this Sero-surveillance cohort doing ELISAs, which are a lab-based antibody test over a 12-month period, doing swabs on some of them, and then an immune response cohort doing more detailed studies, including pseudovirus neutralization assays, which actually take the antibodies from the patients and see if they're actually capable of killing the assays in vitro. And this would include now new variants that are being studied at the Centre for Virus Research. And the PBMCs is the method by which the white cells are extracted from the blood for further studies. Now, so far we've completed stage 1, and I'd just like to share briefly some findings from that. Next slide, please, Tony. And this is the Karonga demographic surveillance site in which we work, and the green circles show where we sampled for this first stage. So it's a very rural area. You can see how scattered the households are, but these 2 areas are where there's a greater population density for people that know the area. One of them is Uliwa Trading Centre, and the other one is Chilumbajeti, where the headquarters of our rural project is. Next slide, please, Tony. Towards the end of December, beginning of January, we sampled 210 adults randomly from these places, and we interviewed them and collected blood samples. It was about equal men and women. The age distribution of the adults pretty much reflected the age distribution of the underlying population. And as we were still in the process of establishing the ELISA tests at our lab, we tested these sera with a rapid antibody test that looks for IgG and IgM, evidence of more recent and past infection. And we identified that 20 out of the 210 by this test, which is nearly 10%. And this is a very rural area, mind you, where we saw very little disease in the first wave, already had evidence of prior SARS-CoV-2 infection. And this is comparable if you look at the data that Tony presented from Blantyre. It's less than the urban seroprevalence, but it's not that far off. And interestingly, about half of these were IgM positive, implying fairly recent infections. So some of these antibody responses would have been from the first wave, and some were from the second wave, galloping through the rural population as well. Next slide, please. I've just done a very quick analysis of these data. So even in this very small sample size in this pilot, young people were significantly more likely to have evidence of recent infection, which is what you would expect. They're the people who are out and about and mixing. There was no difference by sex. And similarly to Tony's study in Blantyre, about half of the individuals who had evidence of infection reported no specific COVID symptoms in the last 2 weeks or since April, although there was an association between recent infection and reported loss of smell or cough. Interestingly as well, even in these populations where if you've been out and about in the rural areas, you would think, how on earth are people supposed to protect themselves at COVID? The markets are crowded, people live in overcrowded households, hand washing facilities are limited, etc. Even in this small sample, the people who reported adopting no COVID prevention measures, by which I mean they said they didn't use a mask, they didn't stay home, they didn't avoid crowded areas, they didn't practice social distancing, etc. They were highly more likely to have evidence of recent infection. So any preventive measures that people can take will protect them to some extent. Next slide, please. So we want to move on to, we're in all standing by and ready to start the main repeat population sero-surveillance study in early February. And our conclusion from this pilot is that there was evidence of extensive recent transmission in this area, that we really should make sure that the main study progresses rapidly. And that particularly with these new variants, which means there's this wave of infection coming very rapidly through, it's increasingly important to understand the transmission, the ratio of asymptomatic to symptomatic in the community, the predictive value of various symptoms, whether prior infection is protective, and also understanding what we are seeing in terms of the immune response to infection and what that will mean for potential vaccine responses. And these questions are all extremely important to inform the public health response in short, medium, and long term. And now I'm going to hand you back to Tony for a final slide just to talk about areas where further support is required. Thank you.
Thanks, Mia. Just kind of put together a last slide thinking about, you know, what the UK government could do to provide support. I added the kind of top one, pulse oximeter, after hearing Dr. Mtumbuka's experience, is that I also look after COVID patients. And one of the key challenges is recognizing people who are ill enough to require admission. And pulse oximeters, when I worked in Malawi, were very difficult to find. They're very cheap. They're £20, can be bought from Amazon, and can really tell you, because patients are very breathless and have low oxygen levels, but often don't feel breathless. Sorry. So these will be really useful. Secondarily, I think the Honourable Minister had touched on testing capacity. You know, I think when this outbreak started, there were initially only like 4 centres that were able to do PCR testing, and now that's expanded massively, and there's now massive expansion in use of rapid antigen tests, which I guess accounts in part for the kind of substantially steeper curve compared to the first wave due to the testing capacity, but that would be really important. Having tried to ship reagents and consumables into the country to do these studies, we realize that Malawi, being a landlocked country, has very difficult access to reagents and consumables from in the African continent. They mostly get it from South Africa, but even that route has been quite challenging in the time of COVID travel restrictions. and certain cold reagents need to be shipped from the UK, for example. And the cost and logistics, particularly in recent weeks, where a lot of the flights from the UK to South Africa have been cancelled due to the kind of restrictions in travel from South Africa to the UK, has been really challenging. So, you know, ensuring that there are good channels to ship reagents and also affordable channels to allow governments to do important surveillance will be key. Mia spoke about the new variants. I think that, I mean, although we haven't confirmed it, it's undoubtedly that the steep rise in many Southern African countries is due to the circulation of the South African variant. In Malawi, there's really limited sequencing capacity and expertise. There is some capacity to do that at the Malawi Liverpool Wellcome Trust Clinical Research Programme, but you know, some support to do that, and we have expertise in Glasgow that can try and support this in order to expand in-country capacity. It's really important to understand that, given that there's just today the Moderna vaccine, it's announced that that particular vaccine is maybe 6 times less effective against the South African variant. So understanding what is circulating in country will be key, and continue to support COVID-19 research, because the disease burden was low in the first wave. We don't really truly understand what the key risk groups are. You know, they may be entirely different from what we see in developed settings in terms of old age, non-communicable disease. Certainly from my past experience with flu research, you know, the risk factors that apply in the UK may not apply at all in Africa. So there needs to be further investment in research, which, you know, during a pandemic, research on kind of epidemiology, immunology and genomics is really crucial to develop knowledge to inform public policy. And thank you very much for listening.
Hi there. Sorry, I wasn't unmuted there, but just to say our final speakers this evening are from EMMS International and from the Mulanje Mission Hospital, respectively. So that's Cathy Ratcliffe and Ari Glass.
Thank you for having us. I'm going to try to share screen as well. Hopefully, is that showing?
Yes, yep.
Okay, well, I'm actually going to speak quite briefly because I'm mainly going to introduce Ari, who's the medical director at Mulanje Mission Hospital. We would have been joined today by the director of the Palliative Care Association of Malawi, but unfortunately today he tested positive for COVID, as did a senior member of staff in the Palliative Care Association of Malawi. So I'm just going to talk first about what our 3 projects are with Mulanje Mission Hospital. The biggest project we're running is funded by the FCDO. It's called Chiponda, Compassion, and that is providing palliative care, or rather developing, improving palliative care in the 4 central hospitals and in 26 rural, hard to reach CHAM facilities, faith-based facilities. So there's at least one of these in every district of Malawi. So during the project so far, we have adapted to provide PPE and provide information in rural areas about COVID, but 3 staff working on this project have tested positive this month. So amongst them, the director of PACAM. One of them is in Mzuzu. She was on oxygen for 10 days. So the director of PACAM wanted to pass on to me this from his experiences of reviewing palliative care in these 26 rural facilities. None of the 26 is able to test for COVID, though some are equivalent to a district hospital serving populations of over 50,000. Every patient with symptoms of COVID is managed as a suspect and referred to the district health office, over 50 kilometres sometimes. Most patients cannot afford to go for the test because of logistics and their physical condition. So really, it's just the same as previous speakers have said, the testing is very difficult at the moment. The 2 other projects that we're doing with Mulanje Mission Hospital are funded by private funds. That's the manufacture of PPE and purchase. So Mulanje Mission Hospital has employed local tailors to manufacture PPE, and they've provided some of this onto Mulanje District Hospital as well as using them themselves. The third project we're doing with Mulanje Mission Hospital is the detection of TB through TB committees in 6 government health centres, and also we're beginning to provide water and sanitation in at least one of these government health centres in South Malawi, which is important in the context of COVID-19. So I'm going to pass over to Ari now, who will speak in more detail about the difficulties he's encountering.
Yeah, thank you, Kathy. Thank you, Alasdair, for having me from Malawi. So my name is Ari Glas. I'm a Dutch doctor, and I'm the medical director of the Mission Hospital here. We are a 240-bed hospital, providing all general services, a large maternity unit, children's ward, the general wards, and also a COVID treatment center at the moment. And we do that together with the district hospital. So between us, we've got about 20 to 25 beds that we can admit patients to. It's been a really strange 2 weeks, a very rapidly developing situation. As we've heard, COVID has really spread very quickly through Mulanje in the past 2 weeks. And what we're seeing is that existing problems that we already knew that were there and weaknesses have now become acute. However, they are not new, and I think that's really important to emphasize here. I would like to mention 4 areas. The first one is staff. Particularly the second wave has put a really large strain on our nurses and clinicians. We work with 17 nurses, of which 5 have now contracted COVID. But we also need more staff, of course. They need to provide screening at entry points. They need to fill gaps for those who are sick. Some are maybe in quarantine. And we also see that government facilities are not well enough equipped to treat corona patients, so they may also come to our hospital for help. And this is all not new. The staff establishments for mission hospitals have been inadequate for many years, and that only comes out more clear now. So that's a big priority, to put more healthcare workers in the Malawian healthcare system. Of course, we do efforts to keep our staff safe. We provide PPE, other supplies, counseling, send people home if they get too tired. But there still is a high risk of burnout, psychological complaints during this crisis. Second element is that mission hospitals like ours have a very complex funding background. So some of our funds come from the government, for example, salary support. Some treatments are reimbursed through the government. But for a lot of it, we are still dependent on external donors, and that's exceedingly complex. For example, in 2020, we ran 5 COVID-19 projects with different donors. All had their own accounting and reporting requirements. And typically, a hospital of our size has 5 management members. So you can imagine that becomes difficult to manage. And that goes back to staffing problems as well. And again, that's not new. Thirdly, supply chain problems. Multiple donors have funded COVID activities in the country, and a lot of supplies have actually reached Malawi, Lilongwe, Blantyre, but very little has actually trickled down to the district level, let alone rural health centers or rural hospitals like ours. So there are bottlenecks, there are stockouts here, but large stocks somewhere else. Pilferage is an issue, which means that we, as a mission hospital, we sometimes rely on private suppliers. And they've become very expensive during COVID-19. So that's a concern as well. So obviously there's need for better supply chains, procurement in bulk. But let's not forget that many basic drugs have been unavailable for 2 years now, especially for pediatrics, for children. So again, that's not a new issue, but it's good that we now realize that it's acute and that we should do something about it. Lastly, I want to talk a little bit about infrastructure. We all talk about oxygen now, and it's good that people realize that there's not enough oxygen in Malawi. And there is not enough, but there's never been enough, because it's not only COVID-19 patients who need that. There's also the mothers who give birth, tuberculosis patients with pneumonia. So let's now realize that we really need to work on infrastructure. We need to put in solar power so that hospitals have reliable electricity 24/7. We have that luckily, but we are one of the very few centers in the country. And then we can actually produce our own oxygen with concentrators, and it's not difficult. But there are huge challenges. Today I received 13 oxygen machines from a neighboring hospital who've got only 4 working and 13 broken. So because of lack of technicians, lack of technical support, we'll try to fix them ourselves and set up the treatment center there. But of course, this isn't new either, and it has always been an issue. So let's try and work to fix these 4 things in the context of COVID. So let's work on staff. And I'm really grateful for the Minister of Health, who has also approved increased staff levels for the mission hospitals and religious health centers. Of course, these people need training. Make sure that resources are available where they are needed. If Scottish partners want to contribute for pulse oximeters, oxygen machines, it's really helpful, but not only now, it's always useful. Let's make sure funds are used where they need to be used. There's been a report that 80% of money raised during the previous COVID wave had been spent on allowances, meetings, teams working on what needs to be done, procurement, and very little has actually gone to drugs and supplies where they're needed now. And now we're faced with shortages. And the donors have the power to change this. So I would really encourage everyone to follow up and hold the ultimate receivers accountable. Let's fix the supply chain and let's improve infrastructure for health, including solar power, not just for COVID, but for all patients, including the 6,000, for example, who died of malaria last year. So that's my contribution. Thank you, Kathy, for this opportunity, and Alasdair as well.
Thank you, Ari. You actually end on a challenging subject, but it's a very useful way to end or to bring the meeting to a close, because I'm now going to invite David to come in and talk about how we draw some of these themes together and what we can actually do potentially together to try and address some of the many issues that you and others have just raised. So David, do you want to come in and talk a little bit about what our next steps might be?
Absolutely, Dr. Allan, thank you very much indeed. Friends, a truly unprecedented number of people taking part in this meeting. 250 organisations and key individuals across Scotland, the wider UK, and Malawi all keen to be involved. And I think that's probably because all of us that are working with Malawi are listening to our friends and partners in Malawi and realising in the last 2 or 3 weeks something is very seriously wrong. In the last week of putting this meeting together, I think every single Malawian that's fed into the last couple of hours, as you've heard, has either been in hospital with COVID, can't take part today because they're currently in hospital with COVID, have had colleagues or family members or close friends that have died of COVID in the last 2 weeks. It's hard in that context not to look at that total official number of 508 deaths of COVID in Malawi in total since March of last year as probably a well-meaning but significant understating of the extent of the problem in Malawi. And I suppose that's what really we wanted to achieve this evening, to make that clear, that clearly it is getting a lot worse very quickly in Malawi. I want to suggest, and I'll do it very quickly, 3 things that I think we could and should do as a community, across Parliament, across civic society, and across governments, to respond to that situation. The first is the immediate support. I think raising awareness of the situation in Malawi is very key, and we will continue to do that. Raise awareness and build support for and meaningful immediate action against the Minister's 4 priorities, as highlighted at the beginning of this meeting: the staff, the PPE, the oxygen, and the face masks. And I think those 4 have been echoed by the various contributors through the meeting. I think there's immediate work that we can do to look at what is the most effective way of fundraising, through whom and to whom. And I hear Dr. Glass's point loud and clear on that, and it's very important that we listen to and are led by feedback from the last wave in that regard. I've got to say, I think oxygen has really stood out from all of the discussions that we've had, and I think certainly the Scotland Wide Partnership's keen to very quickly set up in the next few days or so an oxygen sort of working group to look at what can we do immediately to try and act and offer support in that space. And again, I hear what you say, Dr. Glass. This is not either necessarily a new problem, the lack of oxygen, nor is it a problem that is limited to those suffering from COVID. But I think it is something that we can do. And in the chat box, there's been good discussions between Edgar, Damien, and others about short, medium, and long term. So I think there is expertise there, and the partnership will look to harness that very quickly. So a smaller meeting probably later this week of those directly involved on the oxygen question to look at what we can do, and fundraising. What's the best appeal for us to be raising awareness of? I think there's also an influencing piece within this first strand. Both the UK and Scottish Government very much welcome Minister Jenny Gilruth's strong words at the top of this meeting that the Scottish Government stands in support of Malawi at this time. And I think there's more that we can do, particularly with an eye to the UK government, a budget of around £80 million or so through now FCDO going into Malawi. I think really working with the British High Commissioner to see what is happening now to respond to what we've heard over the last couple of hours. That's all what I would put in the first strand of immediate support. The second is, I think, around sharing and advice. This is a unique crisis because it's one that we as two countries are experiencing concurrently, and I think there is real value to us as a network and a community sharing information and experience. I think the sort of communications point around civic education is probably one of the easiest points to share on, as is mental health, that various people have said, and there was very good contributions about the Scotland Malawi Mental Health Education Project. So we at Scotland Malawi Partnership will go back to hosting regular Zooms like this every month or every 5 weeks or so to support that shared learning, and a very key role of the Diaspora, and full agreement with everything that Joyce said in that regard of working with the Association of Malawians in Scotland. The final point, I think, is on vaccines. WHO said last week, as various people have quoted, 25 people in the developing world have had a COVID vaccine, 50 million people in the developed world, and a catastrophic moral failure. I think probably we're all in agreement of that. The Economist on Friday projected that it's not going to be until well into 2023 that countries like Malawi are meaningfully getting COVID vaccine rollout. I suspect probably we're all in agreement that that's entirely unacceptable and something needs to be done about it. I think probably we all welcome the COVAX commitment and note the UK government's commitment of $1 billion to that, but recognise what's been said, that will only ever at best reach 20% of the population of Malawi, and that's when the vaccines become available, whereas actually that's probably years and not months to reach that point, I fear. I'm really keen to amplify Nick's point about the WTO. It sounds technical, but it's hugely important. The TRIPS, the trade-related aspects of international of IP rights, a proposal from India and South Africa last year that there should be an IP waiver for the vaccines. I think that is the game changer for countries like Malawi. 100 developing countries, including Malawi, have supported that proposal. 9 countries have objected actively to that proposal, and the UK government is one of those 9. I suggest that there is an important moral case for these two parliamentary groups to make to really try and understand why the UK government is objecting to that proposal that would make, through the course of the pandemic, cheap generics available of these vaccines, just the same as there is for HIV and AIDS as well. So I think there's an education piece there. Nick has very kindly said that he'll do a second event to speak more about that, learn more as a community about what needs to be done in that space to understand that advocacy ask and make a clear statement. But my suggestion, and I know a number of the parliamentarians in this meeting have had to leave understandably by this point, but my suggestion is that there are 2 groups of Holyrood and Westminster that come together for a joint statement on the importance of a fast and equitable access to vaccines, and that means the WTO proposal as well. So I will liaise as the secretary of those 2 groups with the members, both MSPs, MPs and peers of this group, to see if there is a cross-party agreement for a joint statement in that regard, to really put pressure, if I'm honest, on the UK government of why it's currently objecting to IP-free access to the vaccines. And I think probably that's one of the really major outcomes for this group. we unfortunately, I know, don't have time for much discussions here. What I would say is we'll keep this meeting, we'll end the meeting, but we'll keep the Zoom live. So please do put any other suggestions of what you think we as a community should be doing in the chat box. All of that will be recorded. And within the next 48 hours, we'll get back to a clear statement of what we're doing, short, medium and long term. So anything you would disagree with what I proposed, or any additional points you would want to see happen, please put it in the chat box. I'll make sure it's captured. But my very final sentence is just say, as I'm sure we're all very grateful, thank you particularly to the Malawians that have fed in with the 2-hour time difference. A lot of people are working extremely hard, extremely long days, and they've given up an evening to take part. So I'm keen to extend thanks from all of us to our speakers. Dr. Allan, back to you.
Yes, thank you. I was also going to say that I appreciate people have been very good to stay for such a long meeting. And I also think that there are certain things that come out of this meeting that I hopefully we can all agree on. I think your idea of a joint statement is a good one about vaccine inequality and IP-free access. It may be that, as well as simply making a statement about that, of course, it may be that there's opportunities for parliamentary debates, other things to raise the issue that I know that parliamentary debates can take a while to organise, but if you can remind me about that, if I forget, then there may be opportunities for things we can do there. I don't know if Jenny Gilruth, if she's still here, if she wants as Minister to respond to any of those ideas, but I think when you mention oxygen is clearly the single theme that's come through many of the, or not the only theme, but one of the themes that's come through, probably related to that theme, is that we should be, as we always try to do in the Scotland-Malawi partnership and in the cross-party group, listening to what people in Malawi actually say they need, rather than giving them what we think they need. So if there is a single thing that we can do around oxygen, that would be, I think, worth pursuing. I don't want to keep people much longer, other than to say that not only will the chat box still continue for a while, but I believe there is also a poll if people want to take part in it in the chat box somewhere. And also really to add that the many people who had comments and questions who I didn't manage to quote from will not have those comments lost. They will be put together and they will be published in the coming days on the Scotland-Malawi Partnership website. We're very grateful indeed for all your comments. We're grateful for the very large number of speakers. I haven't been the best of timekeepers, but as I say, there were some very important things to be discussed at a very important moment in the sad progress of the pandemic in Africa. So it just remains to say thanks to David for the work he's put into this meeting. Thank you very much to all our speakers, but particularly to our two ministers, the Honourable Minister Chiponda and Jenny Gilruth from Scotland. Thank you very much for coming along. I think it was a useful meeting and hopefully one that can perhaps have some practical outcomes too. So thank you very much and good night.
Good night.
Good night.
Good night.
Good night. Thank you.
Good night.
Thank you. Good night.
Good night.
Sanitize and remember social distancing.
Night, everybody.
Good night, everybody. See you next time.
Good night. Thank you. Thank you very much.
Good night, everybody. Thank you.
Good night.
Good night.
Thanks.
Yes. Bye-bye, everybody.
Hello. Bye-bye. Hello.
Thank you very much. It was wonderful.
Hello.
Good night and thank you.
Thank you, David, and everybody. Great getting such a range of speakers. Well done.
Thank you, and God bless.
Thanks, Maureen.
Good night, everyone. Thank you.
Good night. Thank you.
Good night, and please keep safe.
Good night and thank you.
Jenny, thank you for the great work, and we look forward to more of these meetings. Thanks for the great assistance. Good night.